In acetaminophen overdose, hepatocyte death mostly occurs by necrosis, but also to some extent by apoptosis. Overall, acetaminophen intoxication histologically is characterized by a fulminant hepatic necrosis, with the most severe injury in the central lobular area. Also, interesting fact, in acetaminophen intoxication during the first 6 hours, there is increase in liver weight, and after 6 hours, liver weight progressively decreases. The explanation to that phenomenon is that acetaminophen causes damage to endothelial cells that results in vasoconstriction, and with vasoconstriction, blood flow through the vessel decreases, because recall that the resistance is inversely proportional to the radius, so with decrease in radius, resistance increases. And because blood flow equal to pressure difference divided on resistance, with increase in resistance, blood flow decreases. So acetaminophen-induced endothelial damage results in decrease in the blood flow through the liver capillaries that are called sinusoids, and this results in congestion of blood in liver tissue. And with congestion of blood, the volume of blood in the liver tissue increases, and because volume on density is mass, with congestion of blood in the liver tissue, liver mass increases. But after 6 hours, massive lysis of hepatocytes occurs, and with loss of hepatocytes, liver weight begins to progressively decrease. And very high to know that the treatment of choice and the major antidote for acetaminophen intoxication is N-acetylcysteine. N-acetylcysteine is a precursor of glutathione, thereby it restores glutathione stores. So N-acetylcysteine increases the amount of glutathione molecules, thereby more N-acetyl-p-benzoquinone-imine molecules will be detoxified, and the lesser free N-acetyl-p-benzoquinone-imine molecules will be present in the liver tissue. Thereby, N-acetylcysteine prevents binding of N-acetyl-p-benzoquinone-imine to hepatic enzymes, and this prevents damage to hepatic proteins. Also, because N-acetylcysteine increases the amount of glutathione, it causes increase in generation of glutathione peroxidase that increase the detoxification rate of hydrogen peroxide and peroxynitrate, that prevents further pathological pathways. So basically, N-acetylcysteine prevents all major pathological events in acetaminophen intoxication, but as you see, it does not increase acetaminophen elimination rate from liver tissue. It only prevents damage that is caused by acetaminophen. That's why it's vitally important to start treatment as soon as possible. N-acetylcysteine is very effective treatment. It reduces mortality to less than 0.5%, even after severe hepatic injury, which is huge. And on examination, N-acetylcysteine is 100% correct answer for acetaminophen intoxication. And there are 2 other drugs that prevent liver injury, but they are not the first-line treatment and thereby they are not the right answer on examination. The first one is deferoxamine. Deferoxamine prevents oxidative damage. Recall that hydrogen peroxide can be converted by iron in Fenton reaction to hydroxyl radical that is very potent reactive oxygen species that cause oxidative damage. Because deferoxamine is iron chelator, it removes iron, and by this it makes Fenton reaction impossible, thereby preventing oxidative damage. High to know that deferoxamine is the first-line option for hemochromatosis and for acute iron poisoning. And the second drug is cyclosporin A. Cyclosporin A inhibits mitochondrial permeability transition, thereby to some extent it decreases acetaminophen toxicity. In terms of clinical findings, patients with acetaminophen intoxication experience nausea and vomiting within 2 to 3 hours after injection. Then abdominal pain in the right upper quadrant occurs, and after within 24 hours after injection liver dysfunction develops and reaches maximum on 3rd to 4th day. In terms of lab findings, because massive necrosis of hepatocytes occurs, intracellular hepatocytes enzymes are released into the blood, thereby serum alanine and aspartate aminotransferases significantly increase. Also, because significant liver injury occurs, liver detoxification function is compromised, and this results in mild hyperbilirubinemia and hyperammonemia. Also, liver synthetic function decrease. This results in decrease in liver synthesis of coagulation factors, primarily in vitamin K dependent coagulation factors, and this results in increase primarily in prothrombin time. And the well-known fact that children are less sensitive to acute acetaminophen intoxication than adults. The concept here is that the metabolism rate of acetaminophen depends on 2 factors. its size of the liver, and effectiveness of enzymes that metabolize acetaminophen, which is glutathione. Children have much larger liver size compared to their body weight than adults. For example, 1-year-old child has 2 times higher liver-to-body ratio than 14-year-old child, so the difference is huge. And the higher the liver-to-body ratio, the higher are glutathione stores. And because children have greater glutathione stores, they can metabolize paracetamol faster than adults, and this makes children less sensitive to acute acetaminophen intoxication than adults. So simply because children have greater liver size compared to their body weight, they have greater glutathione stores, and because of this, they can metabolize paracetamol more effectively than adults. The exception are neonates, because they have immature enzyme production capacity that cannot provide enough amount of glutathione for appropriate paracetamol detoxification.